Good morning, everyone. The topic for today's seminar is Development, Functions, and Prosthodontic Implications of Tongue. These are the contents. The tongue is a muscular organ situated in the floor of the mouth. It has two parts, oral part which lies in the mouth and the pharyngeal part which lies in the pharynx. The oral and the pharyngeal parts are separated by a V-shaped sulcus called sulcus terminalis. It is associated with functions of taste, speech, mastication, and deglutition. Development of tongue begins at fourth week of intrauterine life from the first pharyngeal arch, also known as the mandibular arch. The tongue is divided into three parts: the anterior two-third, which is arised from the first pharyngeal arch, posterior one-third from the third pharyngeal arch, and the posterior most from the fourth pharyngeal arch. Formation of the anterior two-third. Medialmost part of the mandibular arch proliferates into two lingual swellings. These two lingual swellings are separated at midline by another swingle swelling, the tuberculum impar. Behind the tuberculum impar, the epithelium proliferates to form downward growth, the thyroglossal duct. The depression marked by this downward growth is foramen cecum. Another midline swelling in relation to second, third, and fourth arches is the hypobranchial eminence or copula of His. The formation of posterior one-third. The hypobranchial eminence gives rise to two parts. The second and third arch forms the cranial part, of which only third arch gives rise to the posterior one-third. The fourth arch forms the caudal part, which gives rise to the epiglottis. The two lingual swellings and the tuberculum impar fuses to form the anterior two-third of the tongue. The second arch mesoderm gets buried below the surface. The third arch mesoderm grows over it and fuses with the mesoderm of the first arch. Hence, the posterior one-third of the tongue is thus formed by the third arch mesoderm. The posterior-most part of the tongue is derived from the fourth arch. The anatomy. The external features of the tongue is divided into three: the root, tip, and the body. The body is divided into the dorsum and the inferior surface. The dorsum is further divided into oral part and the pharyngeal part. The root is attached to the styloid process and the soft palate above and the mandible and hyoid bone below. Because of these, we are not able to swallow the tongue itself. The tip of the tongue forms the anterior free end and lies behind the upper incisor teeth. The body has two parts, the dorsum and the inferior surface of the tongue. The dorsum of the tongue is convex in all directions. It is divided into anterior two-third or the oral part and the posterior one-third or the pharyngeal part by a faint V-shaped groove, the sulcus terminalis. The two limbs of V meet at median pit, the foramen cecum. They run laterally and forwards up to the palatoglossal arches. The dorsal surface is covered with papillae, which makes it rough. The inferior surface of tongue is covered with smooth mucous membrane and has a median fold called the frenulum linguae. On either side of frenulum, prominence is present by deep lingual veins. Laterally, there is a fold, plica fimbriata, that runs medially towards the tip of the tongue. Pharyngeal or lymphoid or postsulcal part of the tongue. It forms the base of the tongue and also the anterior wall of oropharynx. It lies behind palatoglossal arches and sulcus terminalis. The mucous membrane has no papilla but has many lymphoid follicles, and collectively it forms a lingual tonsil. The mucous glands are also present. The posterior-most part of the tongue is connected by three folds of mucous membrane: the median glossoepiglottic fold and the right and left glossoepiglottic fold. The either sides of the median glossoepiglottic fold has a depression called vallecula. Lateral folds separate the vallecula from the piriform fossa. The muscles of tongue forms the bulk of the tongue. Tongue is divided into right and left half of the by the septum. That means all muscles are paired. The extrinsic muscles originate from the structures outside the tongue and insert into the tongue. It causes protrusion, retraction, depression, and elevation. Intrinsic muscles originate and insert within the substance of the tongue, causing lengthening, shortening, curling, and uncurling of the tongue. Extrinsic muscles. Genioglossus muscle. Thick fan-shaped muscle which originates from the superior mental spine and it inserts into the hyoid bone. It depresses central part of the tongue and protrudes the anterior part of the tongue out. Palatoglossus muscle are the muscles of the soft palate and tongue. It originates from the palatine aponeurosis and passes anterior inferior to the lateral side of the tongue. It elevates the back of the tongue, moves palatoglossal arch of mucosa towards the midline, and depresses the soft palate. Hyoglossus muscle is a thin quadrangular muscle lateral to the genioglossus. It originates from the entire length of greater horn and inserts into the tongue. It helps in depression of the tongue. Styloglossus muscle. It originates from the styloid process and later blends with the superior margin of hyoglossus and with the intrinsic muscles of the tongue. It causes retraction and it also pulls the back of the tongue superiorly. Intrinsic muscles, the superior longitudinal muscles are present just deep to the surface of the tongue. Its origin is at the submucosal connective tissue at the back of the tongue and median septum of the tongue. The insertion is at the submucosal connective tissue and mucosa on the margin of the tongue. It shortens the tongue and curls the apex and sides of the tongue. The inferior longitudinal, the origin is at the root and the insertion is at the apex of the tongue. It shortens the tongue, uncurls the apex, and it turns it downwards. The transverse muscle origin is at the median septum of the tongue, and insertion is at the submucosal connective tissue on the lateral margins of the tongue. It narrows and elongates the tongue. The vertical muscle origin is at the submucosal connective tissue at the dorsum, and it inserts at the connective tissue in the ventral region. It flattens and widens the tongue. Arterial supply and venous drainage. The major artery of the tongue is the lingual artery, which is a branch of the external carotid artery. The root of the tongue is also supplied by the tonsillar artery, a branch of facial artery, and ascending pharyngeal branch of external carotid. The tongue is drained by dorsal lingual and deep lingual veins, which drains into the internal jugular vein in the neck. Nerve supply is divided into sensory nerve supply. The sensory nerve supply is further divided into general sensation and special sensation, that is taste. Motor nerve supply of all intrinsic and extrinsic muscles except palatoglossus is by hypoglossal nerve. The palatoglossus is supplied by the vagus nerve. The sensory nerve supply of anterior two-thirds of general sensation is via the lingual nerve and special sensation is via facial nerve. And the sensory nerve supply of posterior one-third of both general and special sensation is via the internal laryngeal nerve of the vagus nerve. Injury to hypoglossal nerve. The supranuclear lesion causes the paralysis of the nerve and infranuclear lesion causes the atrophy of the affected site or muscle twitching. Asking a patient to stick your tongue out can be used as a test for the hypoglossal nerve. If the nerve is functioning normally, the tongue should protrude evenly in the midline. If the nerve on any one side is not functioning properly, the tip of the tongue will point to that side. The lymphatic drainage. The tip of the tongue drains bilaterally into the submental nodes. The right and left half of the remaining part of the anterior two-thirds of the tongue drains into the submandibular nodes. Few central lymphatic drains bilaterally into the deep cervical nodes. Posterior most part and the posterior one-third drains bilaterally into the superior deep cervical lymph node. The whole lymph drains into jugulo-omohyoid nodes, which is also the lymph nodes of tongue. Papillae of tongue, those are the projections of the mucous membrane or corium, which gives the anterior two-third the characteristic roughness. There are four types of papilla: the filiform, fungiform, circumvallate, and foliate papillae. The filiform papilla or conical papilla are present at three-circle area of dorsum of the tongue and gives the characteristic velvety appearance. They are smallest and most numerous in number. They are pointed and covered with keratin. Fungiform are smaller than vallate but are larger than filiform. They are narrow pedicle and have large round head. They are present near the tip and margins, but some are scattered at dorsum. Vallate and circumvallate are large in size, 1 to 2 mm in diameter and 8 to 12 in number. Each papilla projection is surrounded by a circular sulcus. The wall has taste buds. They are situated immediately in front of sulcus terminalis. The foliate papillae are present at the lateral border just in front of circumvallate papillae. They are leaf-shaped. Taste buds. They are sensory end organs for gustation. Periform structure made of modified epithelial cell. Each bud has small cavity that opens in gustatory pores. Cells are elongated and are vertically oriented. There are three types of supporting cells: sheath cells, supporting cells, and basal cells. The primary taste sensations perceived in different regions of the tongue are sweet, which is felt at the tip of the tongue, salty at the anterior lateral border, sour at the posterior lateral border, and bitter at the posterior region. Altered taste perception among complete denture patients. The purpose of the study was to evaluate the effect of upper complete denture on gustatory sense in denture wearers. The gustatory senses in 60 subjects were evaluated with 4 different solutions containing sucrose, sodium chloride, acetic acid, and quinine dissolved in water. Means and standard deviation were calculated and then compared between the different time intervals. Conclusion: the study indicates that as the denture wearing period increases, the taste identification time increases, and as the concentration of the given sample increases, the identification time decreases. The most accurate identification was for sweet and salt stimuli, while erroneous identification was found for low concentration, sour and bitter. Function of the tongue is to articulate speech, variation of sound qualities. It moistens lip to facilitate speech, helps in mastication. It also aids in formation of bolus. It contains the greatest number of taste organs and it is a mucin secreting gland. It helps in normal positioning of erupting teeth. It helps to block the trachea in deglutition. The functional tongue classification. The occupational tongue performs activities that require increased tongue action. Occupational tongue implies organ has developed greater range of power movement. Example of those in teachers, jurists, and musicians. Still tongue has limited activity, but injury or deformity. Because of injury or deformity, a passive tongue is present. Normal tongue exists between these two extremes. Habitual tongue, disturbing power movement is developed by habit. Example, arching of tongue to help retain dentures. 8 changes of tongue. Depapillation, which usually begins at apex and the lateral borders. Gradual nerve degeneration. Sensitivity to to taste decline. Hyperkeratinization of epithelium. Tongue frequently becomes smooth and glossy or red and inflamed. The size of the tongue probably does not vary with age. However, tooth loss leads to wider tongue by virtue of overdevelopment of tongue's intrinsic musculature. Glossodynia and glossopyrosis are common complaints in senescence. Prosthodontic implication of tongue. Speech is the mechanical process of producing audible sounds to represent language. The intrinsic muscles of the tongue enables its shaping, which facilitates speech. Voice is mainly produced in larynx and modified by tongue by constantly altering its shape, position by contacting lips, teeth, alveolar process, hard palate and soft palate. Articulation in phonetics is configuration of the vocal tract resulting from the positioning of mobile organs of the vocal tract, example tongue, related to other parts of vocal tract that may be rigid, example hard palate. This configuration modifies an airstream to produce the sounds of speech. The main articulators are tongue, the upper and lower lip, teeth, alveolar ridge, hard palate, velum or the soft palate, uvula, pharyngeal wall, and glottis. The tongue is the principal articulator and changes the position and shape for the pronunciation of each of the vowels and consonant. In pronouncing each consonant, the tongue contacts a specific part of the teeth, alveolar ridge, or hard palate. A working knowledge of this information enables the dentist to fabricate a denture with which speech is clearer. Classification of consonants. According to the anatomic parts involved in the formation, palatal-lingual sounds are formed by tongue and hard or soft palate. Linguodental sounds formed by the tongue and teeth. Example, the. Labiodental sounds formed by the lips and teeth. Example, F and V. Bilabial sounds formed by the lips. Example, B and P. Palatal-lingual sounds formed by the tongue and hard or soft palate. The sound S as in 66 is formed by a hiss of air as it escapes from the median groove of the tongue when the tongue is behind the upper incisor. The upper and lower teeth are separated from each other by only 1 or 2 mm. The sides of the tongue are in contact with the upper posterior teeth and the alveolar ridges. The essential factor in the production of correct S is the proper grooving of the tongue. As the depth of this groove is decreased, the S is softened towards sh, and as the groove is further decreased towards th as a lisp. Excessive thickness of the denture base in the anterior part of the palate is often the cause of lisping. If groove is deep, a whistling sound will be heard when S is pronounced. If the patient produces a whistling sound, the depth of the groove of the tongue should be decreased by thickening the denture base in the appropriate area. T, D, N, and L palatolingual sounds for these rugae area is very important. The tongue must be placed firmly against the anterior part of the hard palate for the production of these words. If the teeth are too lingual, T will sound like D, and if teeth are too forward, D will sound like T. Palatogram, a guide to customized functional palatal contour, a case report. A 52-year-old male patient reported with unsatisfactory levels of pronunciation and speech. On eliciting past dental history, he revealed of getting rehabilitated with complete dentures a month ago. After a thorough sequential diagnosis, it was concluded that improperly carved palatal contour of maxillary complete dentures was the root cause for it. To commence with, the patient was asked to pronounce all words starting with consonant sounds, example S, sh, ch, k, n, and vowel O was merged with the consonant to be recorded, even though their combination is not a word, that is, listening him utter K, we used ko, for ch, we used cho, and so on. The palatal area of maxillary complete denture was sprayed with green food color, which immediately dries. The image shows the palatogram for S and T sounds. The red outlined area shows the under-contoured palate, and with the orange outlined area shows the over-contoured area. Blue outlined area shows the under-contoured area of the palate. The over-contoured area was trimmed, and in under-contoured area, tissue conditioner was added, after which the patient was asked to pronounce to, show, so repeatedly for 10 minutes at faster rate to record the tongue activity during speech. Then the tissue conditioner was replaced with cold mule speech. The image shown here is the polished denture with functional palate with polymerized resin in the deficient area. And these are the verified palatograms for S and T sound. Thereby, to put in a nutshell, initial deviation from the natural speech soon after prosthetic rehabilitation is quite a normal occurrence, and for better comparison, pre-treatment speech assessment is necessary. Palatogram being easy, simple, and inexpensive technique, it is very useful in patients with speech difficulties of complete denture processes. Sounds formed by tongue and soft palate, lingovela. The sound is formed by raising the back of the tongue to occlude with the soft palate and then suddenly depressing the middle portion of the back of the tongue, releasing the air in a puff. If the posterior part of the upper denture is overextended or does not make a firm contact with the tissue at the posterior palatal seal, the sound K will become ch. The palatogram of sound K is typical of the group. This is the palatogram of sound K. The linguodental sounds, the is the representative of the linguodental group of the sound. For example, this, that, these, and those. The sounds are made with the tip of the tongue extending slightly between the upper and lower anterior teeth. The 3 mm of the tip of the tongue is not visible. The anterior teeth are probably way too forward. If more than 6 mm of the tongue extends out between the teeth, and when such sounds are made, the teeth are probably too lingual. Clinical evaluation of tongue. The differentiation should be done between normal tongue and the pathological tongue based on tongue size, tongue position, and tongue movements. The tongue size given by MM House. Class 1, the tongue is normal or ideal in development, size, and function. A sufficient number of natural or artificial teeth are properly distributed to maintain the normal form and function of the tongue. Class 2 is where the natural teeth have been absent for a sufficient period to permit a change in the functional action and form of the tongue. Class 3 is where the tongue is excessively large. All of the teeth may have been absent for an extended period of time, or there may be an abnormal development of the size of the tongue. The rest position of tongue. The dorsum rests against the roof of the mouth. The tip rests against the lingual surface of the lower anterior teeth, and the lateral borders against the lingual borders of the posterior teeth. Tongue position given by CR right. In class 1, the tongue lies in the floor of the mouth with the tip forward and slightly below the incisal edges of the mandibular anterior teeth. This is the most favorable prognosis as adequate border seal can be achieved. Class 2, the tip of the tongue is in a normal position, but the tongue is broadened and flattened. Class 3, the tongue is retracted and depressed into the floor of the mouth with the tip curled upward, downward, or assimilated into the body of the tongue. It is very unfavorable position. An attempt to extend the flange to gain the border seal results in overextension during tongue movements that would dislodge the denture. Management of retruded tongue. If tongue is retracted and depressed, it allows the ingress of the food and air under the lingual borders with loss of peripheral seal. The tongue exercises and counseling should be done. A small training groove of 2 mm width and 2 mm depth can be made below the central incisors of lower denture. The patient is asked to keep the tongue on the groove and thus keeps the tongue in correct position. The other exercises are protruding the tongue out to its most extended position and pulling it back quickly. Exercise number 2 is swinging the tongue sideways with great rapidity. The tongue should be out beyond the lower lip of about 1.5 inch. The other exercise is raising the tongue to its highest position well forward in the mouth through the articulation of U. The tongue movements, lingual frenum attachment should be examined for favorable and unfavorable position in relation to the ridge crest. In case of close attachment to the ridge, surgical intervention may be required, for example, in ankylosing. Role of tongue in mandibular impression making. Adequate retention in mandibular denture can be achieved if lingual surface is so designed that the denture maintains contact seal with the tongue and the floor of the mouth, not only at rest but also in function. Tongue position at the time of impression making has a profound effect on the ultimate shape and success of denture. Lingual flange of the mandibular denture is shaped by the following tongue movements. The anterior region of the alveolar sulcus or premolar region. The patient is asked to protrude the tongue. It determines the length of the lingual flange and is also asked to touch the anterior part of the palate. It helps in developing the thickness of the anterior part of the tongue, anterior part of the flange. Middle region of the alveolar sulcus, mylohyoid region. The protrusion of the tongue causes the activation of mylohyoid muscle. It raises the floor of the mouth, which helps in the formation of length and slope of the flange in the molar region. Posterior region of the alveolar sulcus or the post-mylohyoid region, it is molded by asking the patient to protrude the tongue moderately, to wipe the tongue and to wipe the upper lip with the tongue and to swallow. The lateral throat form is the area situated at the distal end of the alveolar sulcus. Its synonyms are distal lingual vestibule and retromyloid fossa. It is related anteriorly by the mylohyoid muscle, posteromedially by the palatoglossus muscle, and posterolaterally by the superior constrictor, laterally by pear-shaped pad, and medially by the tongue. Classification of lateral throat form given by Neal. Class 1 is deep, which means long and wide flange is present. Class 2 is moderate, which means half of the class 1 and 2 times that of class 3. And class 3 is shallow, which has minimum length and width, ends 2 to 3 mm below the mylohyoid ridge. The extension of the denture into this area can resist horizontal forces, increases border seal, act as a displacing lever on the denture border, and contribute in the neuromuscular control mechanism. Recording the lateral throat form, the patient is asked to protrude the tongue and to swallow. The swallowing movement causes the impression material to move inferiorly and medially. The patient is instructed to touch the right and left cheeks with tongue as it moves the impression material so that the future tongue movements won't display the denture. The role of tongue in jaw relation. Recording vertical jaw relation with swallowing threshold and phonetics is done majorly with the help of tongue. The horizontal jaw relation, the centric relation can be obtained by asking the patient to swallow. This is because the mandible attains centric relation during swallowing cycle. The level of occlusal plane should be kept low so that the lateral borders of the tongue can rest upon the occlusal surfaces of teeth. Role of tongue in teeth arrangement. The teeth must be placed in position near to that occupied by natural teeth, the neutral zone. The teeth must never be set inside the alveolar ridge as it cramps the tongue space, causing the denture movement and the irritation to the patient. Neutral zone, the potential space between the lips and cheeks on one side and the tongue on the other, or that area or position where the forces between tongue and cheeks are equal. The Bersin and Schieser gave the neutral zone definition. The neutral zone is that area in the mouth where during function the forces of the tongue pressing outward are neutralized by the forces of the cheeks and lips are pressing inwards. Recording of the tongue positions and movements receives Close attention in the neutral zone approach. Border seal area for the mandibular denture extends downwards to the floor of the mouth and posteriorly into the lateral throat form. It is advantageous to record the position of the tongue during sucking swallowing movement. Role of tongue in trying stage. The tongue acts as a guide in evaluating the height of the occlusal plane. At rest after swallowing, with its tip gently touching the lingual surfaces of mandibular anterior teeth, the tongue assumes a position in which its lateral border is at the level of the lingual contour of the mandibular posterior teeth. Re-evaluation of vertical height with phonetics is done. Speech evaluation at the trying stage helps in determining the correct position of the teeth. The role of tongue in denture stability. The superior-inferior position of the occlusal plane is determined. A mandibular occlusal plane that is too high can result in reduced stability because the lateral tilting forces directed against the teeth are magnified as the plane is raised. Also, an elevated occlusal plane prevents the tongue from reaching over the foot table into the buccal vestibule. The mandibular denture flange should incline medially and inferiorly, which provides a favorable vertical component to any horizontal directed forces. Inclination of the lingual flange must be designed to guide the tongue to rest over the flange and permit any horizontal forces generated against the denture base to be transmitted as seating forces. Anomalies of tongue and prosthodontic implications. Aglossia and microglossia. Aglossia is absence of tongue, which is very rare. It is in reality microglossia with extreme glossoptosis. Though impression making is easy, microglossia jeopardizes the lingual seal. In such cases, the mandibular denture should be planned to be made with thick lingual flanges with wide posterior teeth while retaining its characteristic shape. Carcinoma of tongue is 25 to 50% of all intraoral cancers. The common site is posterior lateral border of tongue. The causes are leukoplakia, habits, poor oral hygiene, ill-fitting dentures, and caries and broken tooth. Clinically, it presents as an ulcer, fungating, and exophytic mass infiltrating in deep layer of the tongue. Combination of surgery and radiotherapy will be of the greatest benefit to the patient. The term glossectomy is used to describe the variety of surgical procedures for the resection of the tongue tumors. It can be classified into partial or total. Most patients with partial glossectomy, that is less than 50% of the tongue removed, suffer with minimal functional impairment and require no prosthesis. Removal of more than 50% of the tongue requires rehabilitation with either palatal or lingual augmentation prosthesis. This is partial glossectomy and this one is total glossectomy. Completely edentulous with total glossectomy, the treatment plan usually is mandibular denture with lingual flange extending over the floor of the mouth with a mushroom-shaped button attached to it on which the silicone tongue can be placed. After total glossectomy, the floor of the mouth becomes concave and there is a loss of speech and pooling of saliva and liquids. The types of tongue processes based on function. There are single-piece tongue processes. One is for tongue processes for swallowing and second is for tongue processes for speech. A typical prosthetic tongue for speech is flat with wide anterior elevation which aids in articulation of linguoalveolar sounds T and D. It has a posterior elevation which aids in the production of sounds k and g and helps to shape the oral cavity for improved vowel pronunciation. The tongue prosthesis made for swallowing. The prosthetic prosthesis is waxed in the form of sloping trough in the posterior slope to guide the food bolus into the oropharynx. The two-piece tongue prosthesis. The impressions are made with maxillary tray for mandibular arch in order to record the floor of the mouth properly. The base of the mandibular denture extends over the floor of the mouth. A mushroom-like button is made on the mandibular prosthesis so that a silicone tongue can be placed over it. Completely edentulous with total glossectomy and hemimandibulectomy. Treatment 1 is where the mandible is reconstructed with bone graft and rehabilitated with implant retained mandibular overdenture along with tongue prosthesis. Treatment plan 2 is maxillary and mandibular complete denture with guiding flange, which will close the defect. The tongue for swallowing is made with a trough in the posterior aspect to guide the food bolus into the oropharynx. Rehabilitation of partial glossectomy patient, a palatal augmentation prosthesis, a case report. 61-year-old male reported with chief complaint of swallowing and impaired speech due to partial resection of tongue. The patient had adequate mouth opening as seen in figure. Intraoral examination depicted that the lingual sulcus was completely obliterated on the resected side. Patient was dentulous in both the jaws with few teeth missing. The right side floor of the mouth is concave and essentially without function. The floor of the mouth was reconstructed with split thickness flap from his thigh. A self-cure hollow prosthesis was fabricated to work as a base on which the molten corrector wax was applied to make the functional record. Wax was painted using brush on the oral side of the hollow prosthesis, and patient was instructed to functionally manipulate the wax by the floor of the mouth by repeating linguovelar sounds for posterior palatal tracing. And for anterior palatal tracing, the linguoalveolar sounds were used. These sounds enable the tongue to articulate with different positions on palate. Phonetics was checked again, and finally a proper balance was achieved between speech and swallowing tracings. Laboratory putty index was made before flasking to make sure that the patterns recorded were not distorted by any heat or pressure generated. A smooth palate without rugae was preferred by the patient for easy removal of food. The prosthesis was delivered to patient and follow-ups were done after 24 hours and 1 week. After 1 week, speech therapy and oral exercises were initiated to improve the efficiency of the prosthesis. Whenever there is residual function in the remaining floor of the mouth, palatal augmentation prosthesis is considered. The treatment plan thus included fabrication of palatal augmentation prosthesis with oral surface being contoured by functional palatal impression technique using functional wax on oral surface and reproducing the same in the final prosthesis. This is the cross section of palatal augmentation. Addition of wax for linguoalveolar sound is seen. The wax is added on the anterior part of the palate. The wax is added on the middle part of the palate for lingopalatal sound and on the soft palate for the linguovelar sounds. Technical considerations in rehabilitation of an edentulous total glossectomy patient, a clinical study. The patient complained of difficulty in eating and swallowing with no complaint of aspiration. In view of total surgical excision of tongue and completely edentulous state of upper and lower jaws, tongue prosthesis was planned for the patient along with complete dentures. Primary impression and final impression of maxillary and mandibular arch with the floor of the mouth was recorded. On temporary record basis, occlusal rings were made and teeth arrangement was done following recording of jaw relation. Wax up of tongue prosthesis was done on temporary record basis, which was contoured in shape of a tongue that conforms to the oral cavity dimension with rounded edges. At packing stage, heat temperature vulcanizing silicone was packed in tongue space. Heat cured denture-based resin was packed in edentulous ridge space. Curing was done, and after deflassing, the prosthesis was trimmed, finished, and polished. The prosthetic tongue may not replace the intricately mobile structure of the tongue, which is capable of infinite movements in swallowing and speech. The silicone tongue prosthesis does provide the glossectomy patient with certain degree of comfort and function. Macroglossia, also called as tongue hypertrophy or prolapse of the tongue. It is seen in Down syndrome and Beckwith-Widman syndrome. Macroglossia is classified as true and pseudomacroglossia. The treatment is surgical reduction of the tongue size or reduction glossectomy, or by reduction glossectomy. After the loss of teeth, tongue expands into the space created by the loss of teeth, known as proptosis lingualis. The enlarged tongue contributes to mandibular denture instability, is crowded by denture base resulting in difficulty in swallowing. The crowded tongue always presses on the front part of the palate, causing soreness and tenderness. It also causes excessive pressure on the mandibular denture, which pushes it forward and outward every time the mouth is opened. Designing of the lingual flange, polished surface in patients with macroglossia, adding as little as wax possible behind the incisors in the anterior region. Behind the premolars, a flat or slightly concave surface should be established, forming the anterior lingual plane, and it disappears in the molar region. The posterior corner of the lingual flange can be designed to form a posterior lingual rest or lingual shelf for the tongue. If it is not there, the tongue by sheer bulk would push the denture forward and dislodge it. A narrow posterior teeth should be selected and it should be placed higher up at the level of the occlusal plane where the tongue is the widest. Ankylosing tongue tie. The inferior frenal attachment extends to the tip of the tongue and it restricts the tongue movement. The tongue function test, the patient should be able to touch the upper lip with the tip of the tongue without dislodging the lower denture. In the case of close attachment to the ridge, surgical intervention may be required. The denture should be made before surgery as it acts as a stent after surgery to prevent future relapse. Palatal and lingual augmentation processes for dysphagia and other functional problems, a clinical report. This clinical report describes the treatment of a patient with insufficient tongue movement due to bilateral hypoglossal nerve palsy. A palatal augmentation prosthesis and a mandibular intraoral prosthesis were provided for this patient to address his functional dysphagia problems. These problems included insufficient oral to pharynx bolus transportation and a displacement of tongue to the right posterior. After insertion of the two prostheses, the patient could transport the bolus actively from the oral cavity to the pharynx. Bioresin-based artificial tongue prosthesis for taste recognition is primarily meant for taste recognition as well as for speech. The whole unit has two parts. The sensing and the generation part consists of a base made up of bioresin. The surface of the bioresin is impregnated with an array of silicon dioxide, its FETs, that is chemical sensors. The second part is for the impulse delivery, which consists of a current microamplifier integrated with two parts of the flat interface nerve electrodes. The microamplifier amplifies the current generated from the sensors and that is transferred onto the pairs of fine, which carries the impulse further onto the respective cranial nerves. The novelty of this unit is it can act as a very viable substitute for all oral cancer patients who might have lost their tongue, giving back the sense of taste and to a good extent their speaking ability too. 3D palatography is it is an old method which has been used over years to study consonants articulations during speech production. There are two types of palatography: direct palatography and indirect palatography. In direct palatography, the tongue print is directly on the palate, and in indirect, the tongue print is on the artificial palate. The electropalatography is a technique used to monitor the contact between the tongue and hard palate using a palatography software. The computer screen shown behind is the palatography software. This is the data link which connects the smart palate to the computer. This is a smart palate. It is a custom-made artificial palate molded to fit against the speaker's hard palate. It has 124 sensors, which makes it extremely sensitive to the tongue contact. This is the case in which the instruments are kept. The anterior two dots over here is in front of the central incisor is for the lip closure. So the bilabial sounds can be measured with the help of these two. The speaker is repeating the letter R. So here the letter R can be seen on the electropalatography. And here the sound S. The speaker is speaking the sound S. Here the green dots indicate where the tongue should be touching when the sound R is made, and how accurately it's done is given by the score given on the right side. The muscle tonicity is also checked by touching the green dots on the palate, and in how much time it is done is also checked on the time by the time given on the right side. Conclusion: the knowledge of anatomy, physiology, and function of the tongue is an essence to understand the complex morphological and functional changes in the tongue with aging or with complete and partial edentulesum. This knowledge will help us to reach optimal prosthetic success, as tongue plays significant and perhaps the dictating role in affecting stability and retention of the prosthesis. These are the references. Thank you.